Good morning, folks. I'm Peter Stanton, publisher of the Worcester Business Journal, and welcome to this morning's Addiction in the Workplace forum. Few of us want to talk about really important topics when it's uncomfortable, and talking about addiction for most people is one of those difficult issues. Yet it's the very stigma that comes from that discomfort that keeps so many from educating themselves about addiction, about the issues that those suffering from it are facing, and about the best ways to help people, one at a time, to turn around the current scourge. So we're happy to have this audience, you in the audience with us here this morning, and I want to note that one of the folks in the audience I know is our DA, Joe Early, and some of his team. And I just want to recognize Joe because his office has done a tremendous amount of work on this whole crisis. Thank you, Joe, for appearing here. And we've got a terrific group of speakers and panelists joining us this morning for an important conversation about addiction and how those in the workplace can best help the people suffering from its clutches get their lives back on track. There are no silver bullet solutions, but there are a number of proven approaches that offer the best chance at success, and we'll hear about many of them here this morning. You'll also note that we are videotaping this event, and within a few days after editing, we will have that tape available online. We'll send you an email to let you know it's there, and we'll have it on our website so that if you know someone who couldn't make it here or would benefit from this morning's conversation, that session will be a click away, as long as we have the permission of all the speakers. I think we do. Yes, good. So I'd like to thank our sponsors who helped make this forum possible, and that is our presenting sponsor, AdCare Hospital, and our event supporters, the Human Resources Management Association of Central Mass, and the Office of the Worcester County Sheriff. So I would like to invite up for some sponsor remarks Georgiana Cooperman, who's the VP of Marketing and Community Services at AdCare Hospital. Georgiana.
Good morning, everyone, and thanks for coming today. AdCare was more than happy to support this event. AdCare strives to be a community partner and work with as many folks as possible to get the word out about addiction and the services that are available. We certainly work with high schools and talking about educating our students about the first time you take that pill at a party, thinking it might be a decision for that night, could be a decision that you struggle with for the rest of your life. We work with programs like this with the Worcester Business Journal, educating the community, educating employers on how to identify employees in the workplace that may be struggling with addiction. We also work with families. We provide Learn to Cope meeting space in our hospital so that they can bring families together and talk about and support each other. And we also, of course, offer treatment. Most recently, we have made our outpatient clinic open access. So our Worcester program, as you know, when people are struggling with addiction, when they're ready, and it's important to act upon that. So we are now open access in our Worcester outpatient clinic. So we're here and we're happy to support this. And I hope you all bring back some interesting information today to your workplaces, and I also hope you learn some skills to work with your employer. So thank you, and I want to thank Chris Prosser for setting this up for us. AdCare, it looks beautiful, and thank you for presenting us nicely. Thank you so much.
Thank you. So it's my pleasure to introduce our keynote speaker for this morning. Michael Botticelli is Executive Director of the Graykin Center for Addiction at Boston Medical Center and a Distinguished Policy Scholar at the Johns Hopkins Bloomberg School of Public Health. Michael spent several years in the nation's capital as Deputy Director and later the Director of the National Drug Control Policy for the Obama administration. He has more than 2 decades of experience supporting Americans affected by substance use disorders. Prior to his years in D.C., Michael served as director of the Bureau of Substance Abuse Services at the Mass Department of Public Health, where he successfully expanded innovative and nationally recognized prevention, intervention, treatment, and recovery services for the state. Michael Botticelli. Doesn't it sound beautiful? Just that great Italian name, Botticelli. I like saying it. Instead of just saying Michael. And anyway, so here's a question. I was asking Michael about this earlier. So the famous Botticelli. So we have in this room an original Botticelli. It's not the original Botticelli. What is the painter's first name? Who can come up with the famous painter's first name? Hello? Michelangelo? No. Emilio? No. Good Italian name. Begins with an S. Sandro Botticelli. Sandro Botticelli. Michael was telling me he was there in the Uffizi in Florence in front of all this whole room of great classical Renaissance paintings, and he was there with family, and it was a room full of Botticellis with Botticellis on the wall. Anyways, just to celebrate that Italian heritage a little bit, he holds a BA from Siena, another lovely Italian city, but Siena College, I think, in New York, right? And a master's in education from St. Lawrence. He knows the personal toll of substance use disorder and is celebrating his 28th year of recovery. Please welcome Michael Botticelli.
Well, good morning, everybody. Thank you, Peter, for that introduction. You know, I have to say, if there's any Italians in the room, I grew up, in that generation where, it wasn't cool to be Italian then, right? And when when your mother made the eggplant sandwiches and sent you off to school, you got kidded by a lot of other people. But I want to thank Peter and your sponsors for the opportunity to be here today, and also want to thank, particularly AdCare Hospital and Joe Early and the Worcester County Sheriff's Office. They've been incredible partners in this work for a very long time. So what I thought I'd do today is to talk about the impact of the epidemic, and particularly its impact on the workplace, and what I think kind of employers can do as it relates to this issue. I was saying to Maddie Castillo, my longtime friend here, that it's great to see employers as part of the solution to this issue. I think, we have said for a long time, this is an all-hands-on-deck issue. And particularly employers, I think, play a critical role in terms of looking at these issues. So I want to kind of run through a couple things. Many of you have seen these data before in terms of drug overdose deaths in the United States. This is 2016 is when the last time we had federal data here. But just to say that we had over 42,000 deaths in the United States as related to drug overdoses. That's a leading cause of death for Americans under 50. We passed deaths from car crashes, gun deaths, and the peak of HIV deaths. And what I think is particularly troubling, that unlike any other Western country, for the second year in a row, we've seen an overall decline in life expectancy. Which I think is really tragic, largely attributed to deaths from drug overdoses, diseases related to alcoholism, and suicides. And I have to say, and I think you've seen in the news these days, some high-profile suicides, particularly Anthony Bourdain, who had a history of substance use issues. And I think there's much more of a nexus between drug overdose deaths and suicide deaths than we even, I think, acknowledge here. And I think if you talk to people who have long histories of substance use disorders, you will often talk, maybe that's not an expressed suicide wish, but certainly people give up hope in terms of the work that we're doing. So what does the picture look like in Massachusetts? Well, a little bit better picture. In 2017, Massachusetts saw about a 10% decline in deaths, right? So it's still extraordinarily high, but Massachusetts is one of the few states where we've seen at least some reduction in overdose deaths. And I think that's largely attributable to the fact that we spent a lot of time, and I think many of you as community members, of distributing naloxone. Naloxone is this great overdose reversal drug, and we want to make sure we get it in the hands of people to reverse an overdose. But I also think that, we talk about mortality, but there's a significant, the deaths are kind of the top of the pyramid here in terms of what we see. So, for every one overdose death, there were 10 treatments to admissions, to treatment admissions, 32 emergency room visits, 130 people who have a substance use disorder, and about 825 people who are using substances for non-medical reasons, right? So they're taking prescription pain medication in ways that are not healthy or they were not prescribed for them. So, that's just the kind of tip of the iceberg. And I can tell you at Boston Medical Center, when we look at increases to emergency departments and hospitalizations, we see extraordinarily increases in terms of the people who are coming into the walls of our institution as a result of the opioid epidemic. But there are other consequences as well. So some of this is from the National Survey on Drug Use and Health, that they estimate that there are about 2 million adults in the United States with an opioid use disorder. That number is probably twice that amount. The National Survey doesn't poll people in jails and prisons, doesn't poll homeless populations, and it's a telephone survey, right? So even though it's highly valid, it's probably twice the magnitude in terms of opioid use disorders. We've also seen significant increases in viral hepatitis associated with people who inject drugs, and highest rates among young people with HIV. And I think, kind of doubly tragic, we have begun to see increases in HIV among needle sharing for people who inject. After decades of declines, we've begun to see in certain parts of the country and here in Massachusetts some increases in HIV prevalence. And many of us have spent a lot of our time working on HIV-related issues, as well as significant increases in neonatal abstinence syndrome. So these are babies who are born to moms with opioid use disorder. So we've seen about a threefold increase in that, and then obviously incredible expense associated with those issues. So, but let's pivot a little bit to, that's kind of the human toll. But what has been kind of the economic toll of this issues, and it's really extraordinary. So some of you may have seen in November of 2017, the White House Council of Economic Advisors put it out an analysis of the economic impact and estimated the economic cost to be $504 billion. An astounding 2.8% of GDP, 6 times larger than most recent estimates associated with the economic toll of the opioid epidemic. It's just extraordinary. And what they did is about 70%, a little over 70% of those costs were attributable to what the non-fatal consequences, including healthcare spending. We see that people with substance use disorders are some of the highest utilizers. We have this conception of ourselves that like substance use folks are like not intersecting with our healthcare delivery system, and they are, particularly around acute services. Certainly around our criminal justice costs, the extraordinary numbers of people who are in our jails and prisons here in Massachusetts and around the country as a result of a substance use disorder, and lost productivity due to addiction and incarceration. So this has been an impact, and I will have to, I have to say this, that addiction has been taking a toll on our workplace for a very, very long time, and I think, quite honestly, we're finally just paying attention to this issue. And about 27% attributed to lost potential earnings due to death in terms of overdoses. Alan Kruger, who's a Princeton economist, suggests that the epidemic accounts for a 20% decline in labor force participation. So if you're having trouble hiring people and finding qualified people, I think we have to look at kind of the toll that this epidemic has played in terms of removing people from the workforce in terms of labor participation. The other piece, this is information that just came out from the Kaiser Family Foundation a little bit ago. And I think we have this conception in our head, and certainly the prevalence of substance use disorders in a Medicaid and poorer population is a little bit higher. But we also know that prevalence of opioid use disorders in a commercially insured population is very high as well. So where we see about 37% of people with an opioid use disorder are commercially insured. So these are the people generally that you're employing in terms of the work that we're seeing. Maybe they haven't reached that, where they're, homeless or are not able to work but we know that a significant percentage of people who are in our private insurance, and about 38% in terms of Medicaid. So I think it's really, I think it's really interesting for us to think about as employers, and I'll talk a little bit about what BMC is doing around our employers, bless you, to think about this as it relates to the work that we're doing. Again, this is from the same study, really looking at the cost of opioid addiction and overdose treatment has risen. So even though we've begun to see a decrease in opioid prescribing, we know that the cost in terms of treatment costs for this population continues to escalate. Again, this is 2016 data. Estimated about kind of $2.6 billion in terms of the impact of this. So I would encourage you to take a look at this. So this is from the National Safety Council, and it's called the Substance Use Calculator. And it's really interesting because what it does is it allows you to plug in. So this is BMC data, right? So it allows you to plug in the state that you live in, the industry that you have, and how many employers that you have in your company. And it tells you based on prevalence data. This, I will say, this is kind of a blunt instrument, but I think it'll give you an idea for your business. What's the economic toll that your businesses are impacted by as it relates to substance use disorders? So this is BMC data that we looked at this. So, the total BMC, we employ about, just within our hospital, about 7,000 employees. So we're able to kind of look at what are the costs that we are incurring as a result of addiction among our employees. And it estimates at about $2 million. I will say that this is probably very low in terms of those issues. But, and it calculates it in terms of lost time, in terms of productivity, people who are taking, significant amount of absence, who are out a lot. I will tell you that if you see people who are out on Friday and Monday, that's probably a good indication and a good pointer that they might have a substance use issue. And I can tell you from somebody who has a substance use issue that, Mondays were particularly challenging for me to come into work. And my weekends often started on Thursday, and so Friday I didn't necessarily come into work all the time. But job turnover and retraining, people who kind of leave rapid turnover, and particularly healthcare costs, because again, we know that people with substance use disorders are significant utilizers of healthcare services because of all of the problems that they incur. So I'd really encourage you to use the calculator for your own businesses to be able to take a look at what the impact is. So what has been, BMC, what have we been doing as it relates to this work? Again, we employ about 7,000 employees. When we established the Great Consenter, it was not just about how do we do better for our patients with substance use disorders, but our CEO made a real significant commitment to dealing with this within our with our employees. And I think that many of you have probably heard in a very personal way the way that addiction, and particularly this epidemic, has impacted your own employees. It's really hard to talk to someone who has not been impacted by this epidemic. I don't have a slide here, but many of you might have seen in March, Blue Cross Blue Shield Foundation in Massachusetts did a survey of Massachusetts residents around the impact. And it was really astounding because it said that 7 in 10 people know someone who's been personally impacted by this epidemic, and 3 in 10 people know someone who's died. Right? So this, the personal nature of this epidemic really can't be understated, because this has really been a challenge. And I think that we've seen more and more employers, quite honestly, hearing about this from their own kind of senior leadership and coming from their own employees. So what have we done as it relates to basically making this an issue? And Peter talked about this, that this is an issue that often hasn't been talked about within the ranks of our employers. So we did a couple things, and we're doing a lot more work around this issue. But first and foremost, I think many of you know September is Recovery Month. And so we actually had a number of events focusing on the impact of of addiction among BMC's own employees. And we hosted a forum with a panel of people who were talking about how this issue has personally impacted them. And I have to tell you, there is nothing more impactful than hearing from your peers on how this epidemic has impacted them. And we had one nurse talk about the fact that her son, who's now fortunately in recovery, had overdosed 6 times, and basically, don't give up hope on people. So we really tried to basically signal through communications from our CEO that this was really an important issue to do. Well, one of the things, and this is on our website at BMC Addiction, I would encourage you to download and use this. We work in a healthcare environment, but there's still a tremendous amount of shame and stigma associated with disease. And sometimes that's reflected in the words that we use, right? So calling people junkies and addicts, where we don't use that terminology for other diseases. So our CEO sent out a Words Matter pledge to all of our employees, basically saying that we're not going to be using stigmatizing, clinically inappropriate language as it relates to addiction. We don't do that with other diseases, but we still use that kind of language as it relates to people with addiction. It's common to talk about people in recovery as clean, right? So you think about what's the opposite of that, but dirty. And those, people with substance use disorders hear those messages. And one of the things that we know that even these are national survey data, that when you poll people who know they have a problem, one of the biggest reasons that they don't ask for help is fear of what people are going to think, and particularly fear of what their employers are going to think about this. And I can tell you from firsthand experience, I was very fortunate that when I found recovery, I was working for Brandeis University at the time, and I just had an incredibly supportive employer who I felt comfortable talking about, and who understood kind of what I was going through. Now, clearly, still had performance expectations about my job, and that's really what people in recovery are supposed to do, but really created a supportive environment for me to feel free that I could talk about those kinds of issues in terms of what I was going through. But more substantially, we actually sent out a survey to all of our employees. And we were actually astounded by the response that we got. So I think many of you are used to surveying your employees on a wide variety, but of over 7,000 employees, we got about 1,600 survey responses back just on looking at issues around mental health and substance use among our among our employers, and asking them questions like, do they know what benefits that they have available? Were they satisfied with the benefits that they were able to get as it related to them or their family members? We asked about things like culture and climate, right? So how do we think about beginning to diminish some of the stigma and some of the issues that people face because of that fear of repercussion from their employers, from their supervisors? And kind of no surprise, the biggest themes that we got back in terms of the climate, even at BMC, an institution that prides itself on its history of dealing with substance use disorders, that fear of kind of professional repercussions around talking to their supervisor or talking to their employers around this issue as it impacted them or their family members. And I think that atmosphere around other health conditions, if you had a significant issue yourself or with your family members, probably employees feel like free and often share that with supervisors where they don't with issues of addiction. One of the things that we wanted to focus on is, as a lot of attention has come around the opioid epidemic, we can't forget the role that alcohol and alcohol use disorders play. So we actually sent out, with our open enrollment, it's called a Rethinking Drinking card, and we asked employees to do a self-assessment around their own drinking behavior, because we still see that with both our patient population and our employee population, that alcohol has a significant role. And one of the other things that we did too is created a goal for the hospital to reduce opioid prescribing, particularly post-surgically. And so we've been able to reduce opioid prescribing by 25% for people who have had surgeries. The other piece that we are working on, and again, some of this happened organically, where we started getting calls from different employers, particularly in the Boston area, who wanted to know kind of what they could do and how they should think about dealing with this issue. So we have been convening a number of key HR professionals. We just had a breakfast last week in Boston. And what we're developing, and again, we'll make sure that we share this, we're developing an employer toolkit. So as you begin to think about, your response to this, how do we give employers a blueprint for thinking about how they structure this? So, and kind of the blueprint will talk about many of these different areas. And one of the things that you can do is around benefits review and benefits satisfaction, right? So benefits review, look at your claims data, look at how many people are accessing services, look who you're contracting with. And I think you've seen a tremendous amount of public attention focused on really lousy treatment providers. If any of you watched John Oliver, he did this whole segment on shoddy rehabs. So part of it is looking at your benefits and your benefits package, and also looking at who your insurer is contracting with, and making sure that it's the highest evidence-based providers that you could look at. Making sure that your employees have a resource guide. One of the things that we found is our employees didn't even know what benefits they were available, or even programs at BMC. So can we really provide a resource guide for employees? Making sure your benefits plan supports alternative pain strategies. One of the things that I've heard significantly from physicians is, I don't want to prescribe opioids, but my health plan for my patient doesn't support things like physical therapy, acupuncture, cognitive behavioral therapy. So we want to really move away from opioid prescribing and making sure that benefits that you provide support those kinds of alternative pain strategies, as well as opioid prescribing policies. We're in Massachusetts, so the governor has actually basically kind of mandated what those prescribing policies are. But I think it's really important to also look at your pharmacy benefits and see kind of what they have in place as it relates to opioid prescribing policies. Probably most critically is, how do we create a much more open culture on addiction? And I think there are some low-hanging fruit here that every employer can do. Many of you have employee assistance programs, you have workforce wellness initiatives on a whole host of issues, but unfortunately, often we don't talk about addiction as part of those. So, how can your HR department or employee assistance program really do a better job at talking about issues of addiction? It's really astounding, I think, to all of us who've been doing this work. You just scratch the surface, and people will immediately come up to you afterwards and talk about how this has been impacting. So this is right at the surface of people's awareness for this. Nothing can probably supplant communications from top executives, right? So when our CEO sends out a message to all of our employees, it signals from the top leadership of our organization that this is really an important issue that we care about. I talked about employee surveys. When we do our toolkit, we're actually going to give out the survey that we used, and we hope that employers will adapt that. And I think many of you, evidenced by you're here today, by your association with AdCare and others, corporate participation and support for community events is really important. And I think it signals, that this is really a tremendously important issue, as well as the Words Matter pledge. The other piece that I think is important is, how do we provide employment and employment pathways for people who are in recovery, and particularly people in recovery who have a criminal record. I think can be really, really challenging. So, I put ban the box, and ban the box is really a practice about not asking about people's criminal history to farther down in the process, and giving people a chance to demonstrate and to talk about kind of why they might have a gap in their resume, or why they might have a criminal history, rather than just screening people out initially. And the other piece is, how do you outreach to local treatment programs, and can you create employment pathways for people? So here's how it happens. Maddie is here. So, they go around and they try to identify all these different employers who can create these kind of back to work jobs, the recovery jobs that people need to reestablish a work history. So can you kind of look at creating those kinds of partnerships and employment pathways? I keep saying, don't ignore alcohol. Because again, I think it's gotten a lot of attention, but we still know this is one of the most significant problems that we face here. And the last thing I'll say is corporate giving. That many of you have corporate giving strategies, and this has not been a popular issue to focus on as it relates to corporate giving. But I think there's lots of opportunities to think about using resources, foundation dollars, to really help support local programs and local initiatives in terms of the work that you're doing. So I'll just stop there. I know that we're going to have a panel in time for questions, but maybe I'll just if people have a couple quick questions, and then we can go to our panel.
Is the BMC security staff trained in Narcan use?
Yeah, so the question was, is BMC security staff trained in naloxone? They are. And I will tell you, we're no different than many employers. We have many people. If you haven't been to BMC, right across the street is the Boston Healthcare for the Homeless program. We are at the intersection of what we call Mass and Cass. And if you haven't been there, it's really, I think, the flashpoint for the epidemic. So we've seen a significant number of overdoses in our own restrooms. And we're actually putting in reverse motion detectors so that if there's no movement in a restroom, it signals security in terms of the work that we're doing. But it's really important. The other piece that we're doing as an employer, we are encouraging, I think we've done 3 now. We're encouraging all of our employees, and we are hosting naloxone training programs for all of our staff, because our goal is we want to see all of our staff trained in naloxone. Joe?
Michael, are you encouraged by the National Institutes of Health's new announcements about a 6-month Suboxone that can be put under the skin, and immunotherapies that will prevent opioids from getting to the brain? I'd like your thoughts.
So I think it's always good when we have more tools in our toolbox. I really do. And I think, it's really interesting that we're seeing these longer dosages. It can be really, if you haven't been to a methadone clinic, I would encourage you to go to a methadone clinic. One, it's tremendously stigmatizing in the sense that many of our local folks will not let these programs be cited in kind of decent areas. So they're often cited in the worst places of town. You actually have to go every single day for 6 months to get your dose before you go on with your life. And it's really challenging. Can you imagine if you were a diabetic, right? And you basically had to go to the worst part of town every day for 6 months to have someone watch you take your insulin. So I think that the more that we have those kinds of programs, here is, I think, our concern, and we're seeing this with some of like Vivitrol that has 30 days, that people in early recovery need more than just medication, right? And they often need more than daily contact with treatment professionals and peers. So while I think medications have to be part of someone's treatment, it doesn't supplant all the other things that we know to be important. Counseling, participation in 12-step recovery communities. And so I think what we have to be careful of is that we not give the impression that just because you have this implant in your arm that's going to last 6 months, that's going to constitute recovery, because it's not. And we see that even with Vivitrol, which is this 30-day injection that we see often, and this is data from Massachusetts, that we see people getting their first injection, but then we never see them again. We know that when people go through that kind of period of abstinence or treatment, and they relapse, that's when they're at the most significant risk. So to your question, I think the more medications and the more tools we have, not everything is appropriate for every person. But I do think that we need to kind of really cement in people's minds that just being on a medication will not recovery make. That people need all the host of other services, whether it's residential care, whether it's ongoing counseling, and again, participation in recovery communities.
How would you grade our emergency rooms, say just in Massachusetts with rehabilitation and sensitivity training? How would you grade our emergency rooms in treating people coming in with addiction?
Well, I'm not a government person anymore, so I get to say what I really think. I think for a long time, our healthcare delivery system has seen treating people with addiction as an optional activity. I really believe that. And I think that for a long time, the common expression around emergency departments was called treat and street, right? That basically people coming into the emergency department at best would get a slip of paper and say, go help, go find treatment on your own. And we don't do that with any other diseases. And I think that what we've seen is, and this was a study out of Yale University, that I think emergency departments are beginning to implement, that we know if we offer people treatment and actually initiate treatment while they're in the emergency department, that it's better than handing people a slip of paper or even a structured intervention. So I think we need to do a better job and make it standard practice that people in our emergency departments, when they come in for a substance use, now some people don't want treatment, I know that, but we should be doing everything in our power to intervene and starting treatment while people are in the emergency department. And I think it just should be a standard of care. Good. Well, I know one more, and then we'll transition to our panel, and I think we're going to have some additional time for questions and answers.
Michael Cooper from Terra Vista Behavioral Health Center. A potentially loaded question. One that
I like those.
One that the governor was not posed to the governor at the last MHA meeting where I heard you speak. Is this issue of potentially being a 3-day mandatory intervention within emergency rooms buried in his proposed opioid addiction legislation. Do you have a sort of a hit on that, an opinion about whether that's a good or a bad thing,
Yeah.
or the complications that would ensue with that?
Sure. So, one of the things that I think, let me put this in context. I think the governor and the secretary have really done an extraordinary job dealing with this. I don't think we've seen leadership in any other part of the country. So I just want to put that in context in terms of the work that we're doing. So when you look at the governor's bill, what he's referring to is a provision in the governor's new bill that would allow an emergency department or a physician or others who come in who are offered voluntary treatment and don't want to go, basically that you can hold them for 72 hours. They would be sent to a treatment program and be held for 72 hours. As a way, I think the intent is that would engage people in treatment. But I think actually BMC has kind of taken a position on this that we don't support it. And we don't support it because, one, we've done a great job in the state with Good Samaritan laws and other activities to basically create low barriers and lack of fear for people to come, particularly to our emergency department. And many of our addiction clinicians will tell you that they fear that people will not come into treatment, will not call 911 to report an overdose for fear that they're going to be held against their will. The second piece that I think is important, again, we know that people who go through this period of abstinence who don't engage in treatment and who use again are at significant risk for overdose death. So I think we're going to be exacerbating the problem if we hold people against their will. I go back to let's do the emergency department interventions that we know to be effective before we start going down this road of doing that. I think that just in general, the whole emphasis on committing people against their will really needs to be looked at and studied because there is not a tremendous evidence base about whether or not it's really effective. So and I realize it's really good intent, and people don't want to see people die, but I don't think that should point to solutions that might exacerbate the problem and not be a potential solution. Good. So thank you, everybody. Look forward to the panel and for other questions.
Obviously, Michael's got a fantastic talk. He's got some friends in Worcester. We'd like to send him off with a Heart of the Commonwealth picture book, which is a nice commemorative piece on Central Massachusetts. Thank you again for your time.
That's really neat.
For speaking.
Great.
Okay.
Thank you.
Thank you, Michael. Terrific. Thanks, Michael. I'll make it a point to, be in touch with Michael, and as this employer toolkit gets developed, we, through the Business Journal, would love to be, promoting the distribution and sharing that kind of content with our audience here in Central Massachusetts. So, great idea, and we'll certainly be in the game as that gets developed. What I'm going to do is invite up our moderator and our panelists one by one. When I spoke with Michael earlier, he said, don't read my whole bio. I said, don't worry, I'll take a shortened version and go off script. So in terms of these intros, I'm just going to read just a sentence from each one, and we'll ask each of our moderator and panelists to come up. So our moderator is Kimberly Roy. She is the communications director at the Worcester County Sheriff's Office, and the co-author of Sheriff Evangelitis' drug prevention program, Face to Face, a program that's been presented to over 300,000 students across the region about the perils of drug and opiate abuse. Kim. Panelists are Daniel O'Connor, AdCare's Community Service Representative for Greater Boston, North Shore, New Hampshire, and Maine. Dan has devoted his professional life to individuals seeking recovery from substance use disorders, and he continues that work at AdCare, where he refers professionals, families, and patients seeking treatment. Dr. Maddie Castile is the Commissioner for Health and Human Services for the City of Worcester. Dr. Castile, she can be seen working there on weekends, a rare office trip that sometimes gets scrutinized by, anyways, Dr. Castile has always had a professional and personal mission to work with the underserved. In 2009, she founded the Latin American Health Alliance, a nonprofit organization in Worcester dedicated to combating homelessness and drug addiction, and she serves as its medical director. Robert Kilroy is a partner and chair of the... You guys can have a seat. Go ahead. That's all right. And then you can come up one by one, and we'll, cheer you in our minds. Bob Kilroy is a partner and chair of the Labor, Employment, and Employee Benefits Group at the law firm Myrick O'Connell, Damali, and Luigi. Bob has been recognized as a super lawyer who specializes in employment litigation and defense of corporations and their executives. And he also advises clients on a broad range of employment and human resources-related issues. And Nicole Z is the plant manager for St. Gobain's Super Abrasives. Nicole has been climbing the ladder for 15 years with St. Gobain, first starting in R&D, later switching to production manager at their Merrimack, New Hampshire facility, and eventually coming back to Worcester and being promoted to her current position as plant manager. So thank you all for joining us. We've got a number of different perspectives. And Kim, it's your show to run.
Okay, good morning. I just want to first thank Peter and Chris Parser and Worcester Business Journal for inviting me today, along with our distinguished panel, to serve as moderator for this extremely important topic. I want to thank Worcester Business Journal for all that they do for our community to have these educational forums on a regular basis. On a personal note, at the Worcester County Sheriff's Office, unfortunately, we are all too familiar with the opioid epidemic. We see it daily. On average, we have about 6,000 people come through our doors each year. On any given day, today, we have about 1,000 men up there in bucolic West Boylston who are sentenced or awaiting trial. When they come into our doors, 90% have substance use disorder. 50% are actively detoxing when they come in through our doors. Every day we face this. We constantly work on substance use disorders, mental health issues. There are no more mental health hospitals, if you will. We are the de facto mental health hospital. But we don't do it alone. We have wonderful partners. Dr. Castile, at any given day, you will find her up at the Worcester County Jail and House of Correction with medical students. She is a tireless advocate for these vulnerable populations. We have great partners in the city of Worcester and the Worcester PD, and of particular note, our district attorney, Joe Early, who works every day with the sheriff and is tireless in tackling the opioid epidemic. What we do inside the walls of the jail is we work with these folks because most of them are getting out in 2.5 years or less. And they come from, what we do know is addiction, opioid addiction does not discriminate. Rich, poor, urban, suburban, black, white, female, male. So we owe it to you, the citizens of Worcester County, to work with these individuals. You talked, Michael, about job training and recovery jobs. That's what we do on a daily basis. We teach blueprint reading. We teach STEM, manufacturing, so when they come out, they are less likely to hurt themselves, you, or your families, and they can become productive citizens and beat the opioid addiction and alcohol addiction. So again, I just want to thank you for inviting me, and I'm excited to talk to our panel and learn so much from them today. So I'm going to start the first question. I'm going to open it up to the entire panel. Please feel free, whoever wants to step in first. In 2016, Governor Baker signed landmark opioid legislation. In the 2 years since Massachusetts has passed this, what has been the major changes you've seen in your various fields? To anyone in the panel. Dan?
Dan O'Connor. I would say, just from being out and about in the territory where I work for AdCare, one of the biggest issues, I heard the governor initially. I went to a forum down at the Seaport District, and questions that were posed, the housing around the addiction issue, what's going to happen? And that was the big perplexing issue. And what's happened, I know that years back, maybe 10 years ago, you could get people into recovery homes like the halfway houses. But what happened, with the opioid epidemic, like 2012, hitting its peak and just spiraling out of control, what started to happen, you couldn't get anyone into these halfway houses. So anyone in this crowd here today, we could open up a sober house back then. What was to stop us? No constraints, charge like maybe $800 a month or whatever, just get a get well job. That was the terminology. He'd throw a meatless book at the person, go to 12-step model meetings. What happened in an area of Boston, guy was the manager of this recovery home, picked this girl up, super low self-esteem, raped and killed her. Boston Globe did a big expose on this. What can be done? I'm on the board of Moore Mass Organization on Addiction Recovery. I posed that question. What can we do? So the Recovery Homes Collaborative, all the halfway houses got together and they started MASH. It's not perfect, but they go in, they audit anyone who wants to be somewhat of a preferred place is on this certified listing of sober houses. And at AdCare, we have a placement service. We go out and audit any place that we send anyone. Like Michael Botticelli was so great to say about Narcan. Like, I always make sure they have Narcan on the premises. Mm-hmm. I always try to make sure that the person is getting the get well job. So they're just not like in a convalescent type of home, like they're actively partaking of their, getting involved in their recovery.
Thank you, Dan. And to the panel, have you seen any particular professions hit the hardest with opioid addiction or substance use disorder? Any more prone than others?
Well, I think overall, I would say that mental health has been the hardest hit. It's much more difficult to get people into treatment. There's certainly a lack of mental health providers. We are losing mental health providers in our community, partly because of reimbursement. And so how do we keep mental health providers? So I think Michael said that one of the things that we need to do is, besides medically assisted treatment, is that we also need to provide therapy, whether it's 12 steps, whether it's, and it definitely has to be mental health treatment. And so getting people into treatment has been a difficult piece. Sometimes there's a waiting list of months to get into to see a provider. And in particular, if somebody doesn't speak the language, that's even a longer time. And so at a time when it's crucial to have mental health available, we notice that that outpatient treatments are being closed, that mental health beds are being closed. And so how do we continue to advocate? We know what just recently happened, but that's just this piece. It's a broad picture that we need to advocate for more mental health services.
Thank you, Dr. Castile. For the employers out in the audience, if I suspect one of my employees is suffering from addiction, what are the steps that I should take as an employer?
I'll jump in since I'm the employment lawyer. So I would say the first thing is you want to make sure that it's well known that you have an EAP, a confidential program that you can refer your employees to. A lot of times employers are concerned about stepping into the mix when they suspect someone may be having either mental health problems or addiction problems, and they're afraid because there's also, under the rubric of the Americans with Disabilities Act, the regarded as prong of disability discrimination. So even if you're wrong about the individual having an addiction problem, you may have handed a potential claim to a plaintiff's attorney by regarding that person as disabled. So oftentimes HR folks, management folks will stay away from trying to intervene. What I'll tell you is you're already pregnant with the regarded as claim anyways. It's already there. You've already noticed a change in behavior or a change in performance. Someone who was once a great performer is now showing up late constantly, is now missing the Mondays or the Fridays, that type of thing. You've got employees coming to you saying, we don't know what's going on with Peter. He's acting very different in the workplace now. At that point in time, I would get the HR folks involved. If you want to contact your legal counsel, do so, but certainly get your HR folks involved to intervene. It's known as the interactive process dialogue, and if you remember nothing else about interactive process, you start with, we're noticing some issues, how can I help? And keep the focus on how can I help you be successful in performing the essential functions of your job. And then it's an open book for them to disclose whatever they need to disclose and then get them the help that they need, essentially.
Thank you, Robert. Nicole, over at St. Gobain, are there any best practices as an employer that you do to help prevent or treat addiction? And when do you feel it's appropriate if you do suspect someone is struggling with addiction?
So we're a pretty close-knit family. We've had a lot of 3 and 4 generations, so they're kind of constantly looking out for one another. So pretty early on, we get an indication that something's changed, and the first is a conversation with HR, just to basically say we're here to help you. It's much easier for us if you can work with us and we can get you the help. So it's referring them to the EAP and trying to work with them on an individual basis. So I don't know that we have a toolkit or anything like that at this point, but it's much more about just remaining with our doors open and first starting with the employee's best interest. So don't worry about your job. This isn't about your job. This is about trying to help you as a person. And as a result, people are open to disclose. And the first referral is the EAP, and then beyond that, helping them to get in any treatment or make the connections necessary through a healthcare provider if they do need any additional support.
Thank you. So I'm going to jump around a little bit. So Robert, I'm going to go back to you. Do you sense companies are becoming more sympathetic now due to the influx of the heightened opioid crisis?
I'll be the bearer of bad news. Unfortunately, I'm not sure I'm seeing that across my client base, and that runs from small mom and pops up to Fortune 50 clients. I think there's becoming greater sensitivity and awareness and an ability to accommodate based on medical marijuana use. But opioids, I'm not seeing it as much in terms of programs. I was fascinated by the toolkit that's being developed by Boston Medical. I think that's unique. I have not heard that anywhere else among my client base, and I have healthcare clients as well. So, so I'm not so sure I'm seeing a greater change in sympathy. And in fact, unfortunately, I think that oftentimes you've got the manager or the HR professional who's dealing with the person who hasn't disclosed an addiction, who hasn't disclosed any problem, but all they're seeing is misconduct, showing up late and so on. And their focus becomes on how do we manage this before it becomes a major problem for them. And oftentimes that may mean managing from a disciplinary perspective as opposed to managing from a getting help perspective. So I think there's a lot of education that can be done that's probably not being done.
Thank you. Dr. Castile, how is addiction impacting the city, and what can employers do to help?
So just to know that there's been 1,238 non-fatal overdoses that were recorded by our police department, which was an increase from 2017. We had 70 confirmed deaths, which was a 4% decrease from the previous year. In particular, in the city, some of the things that we're noticing is obviously public safety, and that's been an increase, whether it's the fire department calls, the police department calls. So all our resources are really devoted into that, so there's increased calls. There's also, we developed a team at the city called the Quality of Life Team, which actually goes out into the community. Not only does it look at encampments in the communities for homeless, because those numbers have increased, but it also looks into helping people with mental health issues, which goes hand in hand with addiction, or people who are looking for treatment and how do they get them into treatment. So there's the whole team in the city that was just developed for that. Our libraries are a place where people can actually go and sit down and have a place. If they're homeless, they're sort of in between a pantry and then no place to go, and they end up being at the library. And so our librarians have become social workers because they are there to help people. We're trying to look for more ways of how we bring outreach into the library. Obviously, the homeless piece has grown dramatically over the last couple of years for us. And we have started a homeless task force, a city manager's homeless task force, really to look at what we can do and how do we improve and how do we put all our resources for that. But also to look at affordable housing, because people, when they're in a treatment we advocate for people being in treatment, and yet if they're in a treatment facility for more than 90 days, they're no longer considered homeless and eligible for HUD funding, so they have to look for availability. So if they can't get jobs and if they don't have the financial capability, we sort of just repeat the cycle again. And how can we help employees? And I'm sorry, I'm taking a long time.
No, you're great.
So I want to say that first is to understand that 16% of the U.S. population, or 40 million people aged 12 and up, meet the clinical definition of addiction, and that close to 75% of all illicit drug users age 18 and over are employed. So it's happening in the workplace. And then employers must pay attention to their staff and get to know everybody better. And I think this is the biggest piece. Is one of the our former Surgeon General also talked about loneliness and the ability to get to know your community and get to know people. And that's one of the most important things that we need to know, is actually get to know everybody better. Sort of that humanistic point of getting to ask somebody, how are you today? How are you feeling today? What's going on in your life? And I think that that's how you're going to know what's happening. And people are going to react to you by knowing that you care, and they're going to be able to let you know what's going on. And I think Michael talked about all the issues that happened, whether there's mood swings, whether people don't show up on time. Those are all things that could be that. Sometimes I think that's me, and I don't have that problem, but I think it's just called stress. And so, but I think it affects everybody in that sense. So that humanity piece, I think, is crucial.
Thank you, Dr. Castile. Dan, I'm going to combine 3 questions in one for you. So Nicole had mentioned an EAP, and for employers, some of us might not be familiar with what that stands for. So briefly, if you could just explain
Sure.
that. And also for employers, what are some of the best options for employers who want to help their employees, get them help, and some of those treatment options, what are they?
Okay, so the first one is
EAP.
EAP. First off, I'm the product of an employee assistance program. On this topic, that's why I was ecstatic, I guess, and maybe you use a better word. I'm absolutely grateful to be presenting on this here and be as brief as I can. Employee assistance programs, they go back to the 1940s, and they've always improved from alcohol being the piece to mental health to now you have hopefully a comprehensive. So employee assistance, starting one, there's this association, the Employee Assistance Professional Association. They have the standards. So that would be one way of contacting them,
Okay.
getting the standards of how to get one going. The other question, what was the second question?
So let's say an employer reaches out and,
Yes.
and has that, and they want to help they see an employee struggling with substance use disorder. What are the best options for them, and what are some of the treatment options available?
What are the best options for an employer
Who wants to
helping-
get help for a struggling
Well,
employee?
first off, the employer, they have to know, the advertising of the employee assistance program has to be there. Like I see when I used to work, KGA is here today, and they had one of the best comprehensive programs. They advertised it. So it was inviting, it wasn't complicated, it was real simple, calling a number. They used to advertise it in you get your paycheck, they would advertise it. So you would know to call up one of these counselors, and they would vet through like what is going on with you. So that's one of the ways. And the treatment options, a lot of times like parents, I find they want to go right to go, meaning my son or daughter needs to be in a detox. And vetting through that, like not everybody needs to be in a detox.
Mm-hmm.
Like sometimes people can go to outpatient services there, but a lot of times the way it runs, someone goes to a detox, they're in there, Chapter 258, when Governor Baker came on board, he tried to make Chapter 258 up to 14 days. You try to keep people up to 14 days in a program. Doesn't always work out that way, but that was the whole crux of that, to try to keep people, because the longer you keep someone in, you're giving the people who are the counselors, the case managers, time to set up a plan. Like I did my internship when I was in grad school at a place, and I learned right away, discharge planning happens the moment the person sets foot, because time flies so quick. So you don't want to be all of a sudden, where am I going to send Joe or Susan when they're done here? I have to have a plan of action. So you have someone in detox, case manager, where are we going to send them? Well, him or her, we want to try to, because evidence-based, the longer you keep someone in treatment, the better the outcome. So you're wanting to send them to more counseling. Like I know where I work at AdCare, we have intensive outpatient. You try to get someone in intensive outpatient. If they don't want to do that, you're trying to get them hooked up in the one-on-one, because the dynamic of one-on-one, people are only sick as their secrets. You can pull it. Clinicians are all trained. They can pull information out of them, cut through the ambivalence. And if that's not the case, let's say someone has habitually been relapsing, you're trying to get them into some type of sober housing situation where you're getting them hooked up with counseling again.
Thank you, Dan. And it sounds like a big part of it for employers with the EAP and letting them know. You said advertising it. And I know the administration and Secretary of Health of Human Services, Mary Lou Sutters, remove the stigma. Like, let's get rid of the stigma behind addiction. Let them know there is a helping hand out there. So I think that is a big part of it.
And the confidentiality is a big thing. Like, I just did a presentation last week on this topic, and I had someone recently say to me, Dan, what do you think the biggest barrier is? And I'd say that a lot of people still have that, if I tell someone a secret, they're going to blab it, meaning, so confidentiality,
Super
stressing
important.
the confidentiality, and when you break that, that famous law case, Task Force versus Regents, the time, threat of person, threat of an elderly person, threat of a child, but letting the people know that it's okay to have a problem, and like Michael was saying, the stigma around, so we have to continue doing that.
Thank you, Dan. Nicole, at St. Cobain, how have you and other managers had to educate yourself on the issues of substance abuse and opioid addiction? How have you gone about that as a company? And having that education, can you share with some of the other employers here? What are some of the red flags that you, and Dr. Castile talked about that a little bit, that you might see with an employee that may think they have a substance use disorder?
Sure. So education first, especially as the opioid crisis came along. We've started to partner a little bit more with the Worcester Police Department. They've come in, they've trained our security team. They now carry Narcan as well, so that if we have an emergency response, they have the ability to respond to that, and unfortunately have had to do that. So first is kind of just educating ourselves on the treatment aspect of it. Beyond that, it's almost on a case-by-case basis, just having an open dialogue, not only with our HR team, but with our legal counsel, to understand case by case what are our options in various situations. So if someone has declared that they have an addiction, that's very different than if they're showing symptoms and haven't declared anything. And so just teaching ourselves what we're allowed to do and not allowed to do as a management team has been very helpful. We've also essentially whenever we've had a situation, we've essentially created a barrier around the situation so it remains confidential as much as possible, which is sometimes hard to do when you've had something happen in the middle of say, a manufacturing facility. How do you kind of put a bubble around that so only a very small number of people are involved and the remainder just have heard someone's sick or doesn't feel well, so that it doesn't become a very public issue, because we are very close and close people tend to talk. So managing the kind of outfall of response is one thing that we've worked on recently. Sorry, what was your second question? I blanked out.
Just now with that education,
symptoms.
and Dr. Castile kind of alluded to, like in the back of your mind, are there red flags that you see, tardiness or?
Attendance is the biggest one. Attendance generally is the first sign for us that something's changed. Careless errors are another one that comes about, whether it's mental health or addiction, seem to be the kind of number one and number two situations. If someone who's done the job for 30 or 40 years starts to make careless errors that could potentially put themselves at risk, that's usually a red flag to us that something's happened. And the first question is, how can we help you? We've noticed a change. Beyond that, chatter. As much as we probably shouldn't listen to the chatter on the floor, if we start to hear that so-and-so's having a problem, or someone comes to advocate for them, to say, I'm really concerned about Joe here, we at least pay attention to those signals and see if we can't offer a helping hand. But it's a variety of avenues.
Thank you, Nicole. Robert, from a legal standpoint, if an employer wanted to establish a program for an employee who's struggling with substance use disorder, to help them keep their job, their employment, as they go through the treatment process, what do they need to know from a legal standpoint?
Sure. So from a legal standpoint, once the individual comes forward and self-discloses that they have a substance abuse problem or a mental health problem and they need assistance, you now are obligated to provide assistance, provided it's a reasonable accommodation under the law. And the only time you really get beyond that is if you face an undue hardship, which is a very high defense, high bar to overcome, and typically it's because the individual would pose a threat to someone in the workplace. Barring that, you're going to provide some level of accommodation. That may be time off for treatment, it may be supporting them with respect to being able to go to AA meetings. It could be any number of things that would allow them to be successful in their job. And that can run for 6 months, it could run for 9 months in terms of providing additional treatment or support. So first thing is the individual self-discloses, know that you're now on the hook. I say that from a legal perspective in terms of being required, obligated to provide reasonable accommodation. And then I go back to what I talked about earlier, which is the interactive process obligation. And the Mass Commission Against Discrimination, Equal Employment Opportunity Commission look very closely at that, whether or not you've done that appropriately, which is, how can I help? Let's figure out how we can make you successful in the job, get you the help that you need. And it can become tricky, so if your HR staff isn't well-versed in this, then I'd recommend that you contact your legal counsel for assistance in getting through it. And if you're struggling with where do we turn, the employee doesn't know where to turn, we don't have a well-established EAP, then there are plenty. SHRM would be a good avenue to look at, as would be your legal counsel to provide you contacts for places that will provide EAP support.
And to piggyback on that, I know with the change in the legislation, where first and second time cocaine trafficking, the sentencing has changed for that, but it's also increased now for fentanyl and carfentanil. We have mandatory minimums. In that vein, are you seeing the legal rulings around workplace addiction change at all?
I wouldn't say that I've seen legal rulings around workplace addiction change. And basically there's two boxes I place things in. There's the misconduct box, which someone engages in misconduct, the employer is allowed to discipline on the misconduct, and then there's the disclosure box. Someone discloses, says they need help, now you're on, you need to go ahead and provide assistance to enable them to be successful in the workplace. But beyond that, I think the legal rulings aren't changing based on a change in the opioid legislation or otherwise. The only legal ruling that's having a significant impact in Massachusetts is the medical marijuana ruling.
And we're going to pivot to that. I have a couple more questions, and then we are going to pivot to medical marijuana. Dr. Castillo, as a doctor and from a medical standpoint, how is the treatment of addiction changing?
So I think it's been changing over the last couple of years. And as most of you know, we started a drug treatment facility back in 2009, I think. And at that time, you couldn't even talk about addiction. It just wasn't something that anybody wanted to hear about. And I think that, and unfortunately, due to the increases of overdoses and affecting overall the entire community, you know, I started a treatment facility for Latino men because at that time, the rates of substance use in the Latino community was very high. But it's been across the board now of affecting everybody. And so the ability to talk about addiction as a disease, even though we knew that it was a disease from a long time ago, but actually more accepting of the fact that it is a disease and how do we bring treatment into the disease. I think that overall the community, when we talk about that, you know, police department is giving out Narcan, the fire department is doing Narcan, that, you know, the community overall, that, you know, we look at you know, at City Hall now where I work, that everybody carries Narcan. We're still a little bit, you know, so there's still a lot that needs to be done. I think we've brought the topic to the forefront. You know, I still think that, you know, we talk about, or at least I talk a lot about medically assisted treatment, that it needs to be brought into the hospital setting, the emergency room, that they could be the beginning of actually providing treatment and carrying it through instead of sending it back out in the streets. That we are getting now, for example, medical students and residents who are now becoming certified for Suboxone. That's an 8-hour training, so we're doing that piece. We're still trying to work with all the physicians overall and say to start seeing patients. I mean, I think it was sort of the same thing of when we had HIV, that nobody wanted to treat HIV. It's not me, I'm not capable of doing that. It takes, you know, a specialized person to do it. And the reality is that we all can do it. And if actually we got all physicians to start seeing patients and provide the assistance that they need for addiction, I think that would be an incredible push. So we still continue to push for all the things that are needed. You know, mental health is, again, a big piece, and so how do we continue to say that that's one of our biggest problems in our community? When we talk about addiction, we're talking about mental health issues. We're talking about a disease that started when kids were young, that, you know, they started smoking alcohol, cigarettes, marijuana at that time, and that's a lot of what started to move that piece. But why did they start to do it? It's because of bullying, because of stress. All of these things got people to start using. And all of that. So you continue on to say, I need something to feel better. So if we really start looking at it and looking at it from the, you know, I shouldn't say Worcester, public schools overall, all schools, to start really doing trauma-informed care when they're in the school systems, so that we can start preventing some of these issues. But the overarching piece is mental health.
Thank you. And just a follow-up question. Michael, you had stressed the importance of recovery jobs. At the Worcester County Sheriff's Office, we have a saying, reentry begins at day one. Dan, I think you alluded to that with AdCare. Dr. Castillo, you have been a tireless clinician and advocate for this population. And if you could just explain to our audience the importance of helping addicts reintegrate back into society and into jobs, and what that does for their recovery.
So I'm going to have to give a little plug for Cafe Reyes, because that was part of our thought process, was that people were having a very difficult time getting jobs and getting housing. So they can't get housing if they don't have a job. They couldn't keep a job. And part of the piece is that, you know, they've been incarcerated for long periods of time, when we had the minimum sentencing of 5, 10, 15 years that people were in jail. And so when they come out, those job skills aren't there. So Cafe Reyes is a job training program for them. But most importantly, what it does, it actually gives them that support system that they, you know, that they didn't have before. It gives them the structured environment that they need to be in. I also look at it that it really makes the community realize that addiction is no different than anybody else, that you go to any other restaurant, it's no different than any other disease that anyone else has, so that you look at people with addiction in the same way as you look at anybody else. I have rheumatoid arthritis, somebody else has diabetes, we all have whatever we have, and that's what we see. But the structured environment is huge in getting people back into recovery. They also lose all their their social groups. They lose family, they lose friends, and so part of integrating people back with their families, with their support system, whether it's in the workplace, whether it's outside, but actually putting that support group around them. And that's a big piece. And then when they're in the workforce, I think limiting stress and how do we work with stress is a huge piece, because any kind of stress can cause somebody to relapse. So if it's a death in the family, some issue with their families can really cause people to relapse. So how do we bring that support system to the person?
And definitely, and you should be commended for all your efforts and outside of the box thinking. And something we do at the Sheriff's Office, which is a little bit outside of the box, is in one of our programs, one of our buildings, our work release, we have shelter pets come in, shelter dogs that come in, and it's been remarkable. We've had 50 dogs come in. We work with Second Chance Animal Shelter. It has reduced the stress level, not only for the inmates, but for the staff. Some of them, a lot of them unfortunately come from a lot of dysfunction. This helps them with bonding relationships. Some of them tell me that, it's like having a kid there. They love it like a child. We found the recidivism rates, we've tracked them. So on average, it's 50 to 60% for general population. It's down to about 20% or less in this building using pets that were considered unadoptable because they nip, they bite, they jump. So what do inmates have that the rest of us don't have? And that's time. So we train at Second Chance, train them, and it's been the best thing. We even presented at a national corrections conference, and sheriff's departments from around the world, around the country, and only 3 of them were using shelter pets. So it's just another way of outside of the box thinking to help tackle addiction. So now we're going to pivot to, I'm sure, what most of you are interested in, and that is with the new passage of marijuana laws. We'd really like our panel to really weigh in on this. I'm sure people have a lot of questions, and I'm going to open the first question up to the group. With marijuana soon to be legal to buy for all adults in Massachusetts, how will that impact everything from detection of addiction in the workplace to treatment? And that's for anybody on the panel who wants to weigh in.
I can start, I guess. We have not taken a hard stance at St. Cobain up to this point, other than to say that safety is our first priority. And with our employees interacting with machines on a routine basis, anyone who's under the influence of anything has a significant risk of injury. So I think the idea is, because of the nature of the job, we have a requirement to maintain our drug and alcohol policies. So if we were to have an injury and there was a suspect in the use of any kind of substance, we would have the follow-through of testing. And the challenge with marijuana specifically is you don't know if it was done this morning or if it was done 29 days ago. So that makes it challenging for us, but I think at this point we have to maintain the policies, or at least that's the stance that we've taken up to this point, just knowing the inherent safety risks. But again, it has to be directly linked. It can't be someone tripped in the parking lot and the assumption is that they were under the influence.
Correct, and that's sometimes tricky.
That is also very tricky.
Right,
Yes.
to prove. Robert, from a legal standpoint, what are the legal challenges that employers are facing, and how has this new law changed the role of workplace drug testing and screening?
Sure. So it's a little bit complex because you have the medicinal marijuana law and you have the recreational marijuana law. And I'll hit kind of the legal ramifications, then I'll give you the practical side in my view. Legal ramifications are recreational marijuana law does not change anything with respect to employment. Employees still can't use, they still on site, they can't be impaired on site. And in general, unless they have a medical problem, debilitating medical condition that would require medicinal marijuana, recreational marijuana is, the laws of recreational marijuana don't change how employers would deal with situations in the workplace. Now, practically speaking, having said that, a lot of employers now are going to, if they're doing entrance testing, applicant testing for marijuana, they're going to have a whole host of additional folks who are going to test positive because it's legal and because individuals now think, well, of course I'm allowed to use marijuana because it's now on the books as lawful. So practically speaking, unless you're in a safety-sensitive industry or safety-sensitive positions, my advice to most employers is you probably don't want to test for recreational marijuana use for applicants, because what are you going to, you're not going to have an applicant pool left, in a sense, for a lot of manufacturing environments. So I think you need to be careful along those lines. On the medicinal front, however, if someone is, and this is a change within the last year, if someone tests positive for marijuana and it turns out they're a card carrier, they've been prescribed medicinal marijuana, you now have an affirmative obligation to engage in the interactive process and to try and accommodate them. And to put it in practical terms, what I offer to employers is the idea that you certainly wouldn't challenge someone in the audience right now if they had debilitating back pain and were taking Percocet. You wouldn't go to them and say, we want to test you for Percocet, and because you're on Percocet, we're now going to fire you, right? What you would look for is, in the workplace, are they impaired in their ability to do their job? Are they slurring their words? Are they falling? You know, those type of things. If the answer is no, then you wouldn't take any action against them. And the same should hold true of medicinal marijuana. Consider it as any other prescription drug. That's how the MCAD is looking at it. That's how the Supreme Judicial Court's decision last year looks at it. So you would look to accommodate. They still can't be impaired on the job, and so you can think of it in the same way you would think of alcohol. We don't test people for alcohol use unless we detect impairment.
Thank you, Robert. Nicole, what hurdles are you finding in your business with the new marijuana use law? How are you balancing that with your corporate drug policies and safety policies, for that matter, given that a lot of your employees are using machinery? I think you kind of alluded to that a little bit before, but anything you want to add as far as?
Yeah, really nothing has changed, even in our incoming screening process. And perhaps as this continues, we'll have to revisit that. But at this point, nothing's changed, just due to the safety requirements of the job.
Dr. Steele, anything you want to add as far as the legalization of marijuana, pros, cons, good, bad?
Let's see. I worry about marijuana out in the community, and in particular, I worry about marijuana for kids. I worry about the marketing of marijuana, which is exactly what they did with the marketing of cigarettes. When they start making the candy, the chocolates, and all of that, that kids are going to be attracted to. And again, I think that education, I think that you know, it's tough because you're fighting, you know, a big corporation to do this, and I think we have to be stronger than that. We have to be able to educate. We have to say what we think is appropriate. I mean, I'm just thinking about, even we just went through flavored tobacco, trying to get that off the mom and pop shops, the gasoline stations and all of that, because kids see it, and that's what kids gets attracted to. We did it from cigarettes, we went to vaping, and so it's the kids is what I worry about. How are we going to look at this in school systems? How are we going to deal with marijuana in the school systems? Because you're going to see it, you see it now. And when are we going to bring the therapists and the counselors in to start talking and to really change that process?
Mm-hmm. Anything on AdCare's end that now with the new passage and legalization, how your approach to when your clients come in?
Well, I know that, like, when I saw this forum and some of the questions, I asked a bunch of the labor unions that I deal with, and pretty much they said the same. I asked them, is any notification, any change? And 4 of them said the same thing, basically. Dan, we're a drug-free workplace, you know, so treat it like, I tell people to treat it like alcohol. You know, like in a lot of safety, my old job, I used to work for the utility company. People had safety-sensitive positions, like CDL licenses and all that, you know, DOT protocol, being subjected to random testing all the time. And that's what I'd say, if they ring up a positive, doesn't matter if they have a marijuana card or not, DOT protocol Fed regs. If they're going to be in violation, they're going to have one strike against them. So that's the one I keep trying to hammer home, because a lot of people think marijuana is illegal now and I can show up to work, but if you have drug testing in the workplace, unless it changes, they're going to be in a violation of the policy.
Thank you, Dan. And for us at the Worcester County Sheriff's Office, we did have to redraft our policies, and we have to think about it from a two-pronged approach. Even tobacco is prohibited on, you can't even have your car if you're an employee at the Worcester County Sheriff's Office. So any place that we have tobacco, we have the word marijuana. You cannot have it in your system if you are on active duty. And the inmates do tell us it is a gateway. Most of them did start off. They didn't start off with a needle in their arm. So they started off usually with alcohol or marijuana in 7th or 8th grade or whatever it was when they were young. So we have a zero tolerance policy. We have to, it's a correctional facility. In every correctional facility in the country, people try to smuggle in contraband drugs. So we are very vigilant, and we have to have that policy not only inside the walls, but with our employees as well. And we'll just wrap it up. Robert, final question to you before we open it up to our audience for questions. Let's see, the last question I had is, what are my legal rights as an employer when it comes to marijuana use and also addiction in the workplace? And what are the legal rights of my employees? So employers' legal rights, employees' legal rights.
Okay, so I alluded to it somewhat already. The employer's rights with respect to drug testing is, particularly if you have safety-sensitive positions, you can go ahead and test. The employee has a right, particularly for non-safety sensitive, to a right against invasion of privacy. And so, as an example, in my law firm, I could not ask HR to test our administrative assistants randomly for drug use, because they have a right to protect against invasion of privacy. A urinalysis test is inherently invasive, and so we wouldn't be able to do that. On the other hand, if I'm in a manufacturing facility and they're working on heavy machinery or a forklift driver, I could certainly do random testing of the employee in that regard. The greatest right that's been established within the last year for employees is the right to accommodation if they're a medicinal marijuana user. And so, in particular, you have to draw a distinction, safety sensitive versus non-safety sensitive again. If you have an employee who is in a non-safety sensitive position, and that's going to be pretty narrowly drawn. Essentially, if there's a significant safety risk to the employee, to others in the workplace, to coworkers, or to the public, that would be deemed a safety-sensitive position. So if the employee is in a non-safety sensitive position and you have a drug-free workplace, based on policy, just you've established we don't want drugs in the workplace because we think it negatively affects productivity, and that would include marijuana use. You apply that affirmatively across the board. Someone comes forward and they say, I have glaucoma, I have Crohn's disease, I have something else, a debilitating medical condition, and I have a marijuana card, whereby my doctor's telling me this is the best treatment option for me to manage my pain or to manage controlling my weight if I have Crohn's disease or something like that. That employee is in the right. And the employee can say, I need to be accommodated in my medicinal marijuana use. Now you may say, well, but federal law, it's still illegal. Not in Massachusetts. The federal law has not trumped in Massachusetts, nor do I ever think it will. So you need to be willing to provide an accommodation, not an accommodation for use on site, not an accommodation if the employee during the lunch break goes out into a car and smokes marijuana, because now they are going to be impaired to some extent, but certainly an accommodation if it's in their system and they tell you, look, I smoked last night, but I guarantee I'll never be impaired while working on site. If you have that and they have a medicinal card, you're going to need to accommodate them unless you want to lose your lawsuit.
Thank you, Robert. So in closing, I'll just say that, 10 years ago, besides the clinicians in this room, most of us didn't know the word opioid or Narcan or carfentanil or fentanyl. And sadly, tragically, we all know what it is today. We have lost more Americans in this opioid crisis than we lost in the entire Vietnam War. So this is a war in essence. And I just want to thank our esteemed panel who are so educational and provided such insight. I want to thank them for their expertise today. And now I just want to open it up to all of you if you have any questions for them. Thank you. No, I guess we answered them.
We did.
Okay.
That's awesome.
So in terms of statistics and Department of Public Health, when somebody gets into an ER and dies of opioids, I'm curious what gets on the death certificate, and because I've heard about how deaths are reported, it can be claimed as a heart attack or something, and that those kinds of statistics end up really impacting what gets funded. And so I'm curious how it's getting labeled. And
Well, I'll refer to Dr. Castellano or Michael.
Michael. Yeah.
Great. So there's a tremendous amount of variability in terms of kind of recording of those. Sometimes it's the wishes, particularly of the parents, that not go on the death record. But in general, I think compared to the rest of the country, I think actually Massachusetts has a really good reporting on the not only on the death certificate, but the drugs involved in the death, right? That's not true in the rest of the country because often in other parts of the country, it's coroners who report it. Many counties, they're not even a physician, they're elected officials. So I actually do think that probably while there is some underreporting of this issue, I think that Massachusetts has pretty good reporting in terms of both where there's drug overdose deaths and the drugs involved in those deaths, because we have pretty good toxicology screening.
Did you have a question? Okay. Okay.
So Heidi and I are from KGA, Employee Assistance Program in Framingham. And on Friday, I went to the Mass Rhode Island chapter of the EAP, their annual meeting, and there was a really wonderful speaker who basically redefined addiction as disconnection. And it was really very eye-opening. And so everything you've all said today has reflected that. And everything we can do to reduce the cost, the loss of addiction is about reconnection. And, whether it's MAT, whether it's shelter pets, whether it's Cafe Reyes, any of these things. I just loved how it was reframed as reconnection, because when you no longer have fear to talk about it, to spread the word in places of employment, people can come forward, get help, and get reconnected. And I was just very struck with that and just felt like sharing that. So
Thank you.
Right.
I think we're good. Okay. Thank you very much, everybody.
Thank you so much. It was awesome to be on here.
Thank you. Thank you, Dr. Steele. Thank you for everything.
We have one
Thank you, Robert.
we have one more
Thank you.
speaker for wrap-up remarks. I want to thank.
Thank you.
Oops, is this working okay? I want to thank the panel, and I also want to invite up our final speaker for the morning. I'm going to hand these books out afterwards, and so it's my pleasure to introduce Dr. Jim Baker. He's an associate medical director at the Merrimack Valley Hospice. When Dr. Baker spoke at our first opioid event last year, he had recently suffered the loss of his son to an accidental overdose. Since that time, Jim has put significant energies into working to foster a greater understanding of addiction and the pathways to recovery. He's here to share some of his thoughts and insights on the crisis and how we might find our way out of the woods together. Jim Baker.
Thank you for having me. A few days before my son died, about 18 months ago, we continued our conversation about what can be done, what I could do for him as his father, what I can do as a physician to help other people find recovery. And he was very open, he was very clear about it, and the first thing that he said was, "Dad, we have to deal with stigma. That's what keeps us in the shadows. That's what stops us from coming out and seeking treatment and getting our lives back, but that's what we want to do. That is step number one." So I really want to tell all of you here today as business leaders and people in recovery and public health officials that what you're doing, coming together, talking about this as an illness, as a disease that needs understanding and treatment rather than punishment, is erasing that stigma. And I thank you for that. And I listened to the presentations today, and I think, so where do we go from here based on what we've talked about and what we've learned? And as you go back to your different places of employment and go back to AdCare and go back home, I learned something this morning. What are we going to do? And as Michael pointed out, I think step number one is to develop a policy that makes sense, to be proactive, to be ready. Because it's in your place of employment. The hospital across the street has thousands of employees, so probably hundreds, certainly dozens of people right now have addiction. That's the way the numbers work, and it's real. And so they need to be ready. You need to be ready in advance. And so I think step number two, after you get that organized plan in place, is it came up in this panel here, how do you recognize signs of addiction? And how do we know when someone has a problem and they may need help? And I certainly agree that missing work, being tardy, unexplained fall off in performance, those things are absolutely part of the big picture. But earlier on, what you're going to see is they're always wearing long sleeves every day, every time, no matter where you are. They're going to have drooping eyelids. Their speech is going to trail off. They're going to be falling asleep in the middle of a meeting. And look at their pupils. They're going to be pinpoint. And has anyone talked to you about that at your place of employment? Do you know what to look for? And you're not physicians like I am. Plus, I saw my son go through that, but can someone come and talk to you about this is what you look for, these are the early signs that your employee or your family member needs help? And look at the further end of the extreme and what happens when someone is addicted, they go into the bathroom and they inject, and that happens. And then you walk into the bathroom and there is an arm coming out from the stall and their skin is blue. Or you hear a thud when you go in there to brush your hair. Are you ready to intervene? And when we talk about Narcan training, it sounds like going to medical school. Well, this is Narcan. Comes in a little package. You just tear open the foil, swallow hard, just put that tip of the tube in the person's nose and push the button. The spray goes in there, they get 4 milligrams of Narcan. Do you have it there? As Dr. Castile pointed out, they have it at City Hall, the librarians have it, police have it, firefighters have it. Do you have it? Do you have it in your home if you have a family member who's addicted? Or maybe one of your children's friends is addicted? Have you talked to them about it? You can go to any pharmacy and say, "I'd like some Narcan, please," and get it. You don't need a prescription. But do you have it in the workplace? Because it would be terrible if on the 14th floor downtown, someone falls over and stops breathing. It takes a little while to absorb. Is this really happening? Well, it is. And someone call 911. Then the ambulance has to get summoned, come up the elevator with that stretcher, run in there, recognize what's going on, and by then it's too late. But if you had it in your pocket or someone had it in a drawer, you could save a life. And where do you refer people for help? Dr. Castile said, when we're looking for providers to help people get recovery, it may take months. It does. And you asked in the AdCare table about, what about the emergency rooms? What grade would you give our emergency rooms? Well, that's something I know about. I'm an emergency physician. At Mass General Hospital, you can walk into the emergency department day or night and say, I need help. You can bring your child in there. You can bring your employee in there and say, I need help, please help me. And they will, if it's daytime hours, they will walk you right up to the Bridge Clinic and institute treatment right then and there. If it's after hours or it's Sunday, they'll start treatment right then and there, and you can follow up in the Bridge Clinic. That's the only emergency department in this state. And that's the case. If you need help, at last year's conversation at this same meeting, one of the panelists said, if you need treatment in central Massachusetts, good luck finding it. And I know that from personal experience. And that's still the case. So what I ask for you in the business community to do is to ally with physicians. What is happening with physicians is we're writing fewer opioid prescriptions and kind of calling it a day. But we're not stepping forward and learning to provide treatment and opening up our offices to help people. So if this were a room full of physicians talking about dealing with the opioid crisis, the conversation would circle around, we need to prescribe fewer opioids. And there'd be monitoring about who gets a medal for prescribing the fewest opioids. I've heard discussions about we need to monitor babies' cough syrup. That's going to solve this problem. And being judicious about prescribing opioids is important, but I have yet to be at any kind of conference of physicians where people talk about let's provide more treatment. So I'll tell you some answers when I talk to physician groups about providing more treatment. When I say what you need in order to prescribe Suboxone or medication-assisted therapy is called an XDEA number. It takes 8 hours to learn how to do that on your own time. It's free, and it lasts for your career. And I asked a physician, do you have an XDEA? And his answer was, what's that? And I said, it's the certification that allows you to treat addiction. Well, we're too busy, we don't have time for that. And these are other answers. When I talk to an emergency department about, let's see what we can do working together to help people find treatment, find recovery. And the answer was, we don't have that problem here. And when I ask physician groups, the answer is, we don't want those patients in the emergency department. And then when you talk afterwards, the answer is, there's no reimbursement. So what do you do? Where do you go? So I have had very limited success in recruiting my fellow physicians into providing treatment. But you can. We have the district attorney's office here. We have the public health commissioner here. We have Michael Botticelli here. We have leaders in our community and say, where are the doctors? Why aren't you helping us? How hard is it? You're really going to give a patient a slip of paper and say, call this number and hope you get an appointment? They're going to go home and they're going to use, or they're going to go back to their encampment and they're going to use. What they need to be provided is treatment. And I think that between what you know in business and your authority and your leadership and what we are obligated to do as physicians to help the sick, we can work together to provide that treatment and keep people alive. There's 3 steps to that from my perspective, 3 key steps. When you find someone who is in need of help, they own up to it, they talk about it, you brought it up and say, I'm seeing a problem. Yes, I have a problem I'm using, or however the conversation unfolds. What are you going to do? Where are you going to send that person? Do you have someone in occupational health who can prescribe treatment on day one? Is there somewhere you can send them where you know that they're going to have treatment started? Do you have that? And I think the answer is no, but it can be created. And then treatment is likely to be for life with opioid use disorder, for life. So they're going to need follow-up care somewhere with a specialist or through integrated care in a family practice clinic, which UMass does have, but they're going to need that care. And in the interim between they get started on day one, let's suppose the emergency department does start providing treatment. And out there somewhere, there is long-term care. How do they get from over here on day one to when an appointment opens up a month later? Something called a bridge clinic. Again, at Mass General, they have that. And patients can go there every day. I've gone and seen it happen. And they have recovery coaches, and they have counseling, and they have housing support, and they also have medication-assisted treatment, and the system works. Those 3 steps. And I know I only have a few minutes, but I just want to share this with you on a personal note. My son and I were very, very close throughout his illness and his recovery, and then up to the time of his death. And I remember very clearly sitting on the edge of his bed, and I'd go in there in the morning terrified that he wouldn't be breathing. But when his skin is still pink, and he kind of wakes up, and I'd say, Mackie, I don't know what I would do if something happens to you. I don't know if I could draw another breath. I don't know if I'd want to. I don't know if I can do it. And I just, that's how much I love you. And he said, Dad, you got to carry on. You got to carry on for the other kids, because that could happen to me. And you're a doctor. You need to help people. Patients need you. You need to do something. You need to go on whatever happens to me. And that's why I'm here today with you. Thank you.
Whoa. Okay. Thank you, Dr. Baker. Very powerful. So that's what we needed. What do we need to do as we leave this room? Thank you all for coming. I want to thank our speaker, Michael Botticelli, and our wonderful panel, and of course, Dr. Baker for his closing remarks. AdCare Hospital for their support of this event as our presenting sponsor, the HRMA Association of Central Mass, and the Office of the Worcester County Sheriffs, and the Beechwood, our host, Curry Printing, Elevation Exhibits, and Ron Burley for shooting the photography. Thank you all for coming. It's a great event, and I appreciate you all being here. Thank you. If everybody, there was a reference to Cafe Reyes, this wonderful restaurant of Maddie's organization that runs. And by the way, as the crow flies, it's like 3/8 of a mile from here on Shrewsbury Street on the left side. So if you don't know where it is, please go check it out. Wonderful food, very competitive prices, and a great environment. So thank you.